Okay, so we are down to our last presentation, which actually will be given by me. My power, as I said, is iffy. It actually went out, including the internet, of course. And so I'm going to be able to do what I can do and then turn it over to Georgia or Kat, and they will take over if needed. And so let me just bring up my slides because, of course, everything I teed up is gone. All right. Okay. And as I said, this will be the last presentation, and then we'll have time for general questions and then time for networking. Okay. Okay, so we've heard a lot today already about PXE's various manifestations. And interspersed with that, you also heard a good deal about some of the treatments that are coming. And I'm only going to give you a very broad overview of what might be possible. There are lots and lots of treatments in development in different ways, in the sense that you also heard that a lot of these symptoms and signs mimic other diseases. And so other diseases are interested in PXE, and PXE is interested in other diseases. And we focus on and try to support the ones that are uniquely for PXE. However, we don't know from what direction something will come. And even as we learned, for example, PXE was not a peripheral elastin disease. It was a metabolic disease. And then we learned that it was pyrophosphate. And then we learned pyrophosphate was possible to ingest and so forth. The scene definitely changes. This is one of the many, many drawings and lots of disagreement about how this drawing should look that actually talks about what is happening in PXE. It's light years away from when we started in 1995, but it still has a long way to go. And you see here the ABCC6 gene, you see some other genes along the plasma membrane that are allowing various enzymes, proteins, chemicals, whatever you want to call them, to come in and out of the cell. And then the story of PXE, which has again been told and retold and drawn differently. And so I'm not particularly married to this. And in fact, some of the therapies on this slide have since failed. But the point being that there's a lot of pieces of the pathway, and there are different places that one could intercept the process and perhaps make the life and health of someone with PXE better. You heard from Vilko that could be exercise, because exercise, in fact, has been shown by some other researchers to increase the level of pyrophosphate, not only just to keep you healthier overall, or maybe to increase the number of collateral blood vessels and so forth, but also to maybe raise the level of PPI. Would it be enough? We don't know. There's also a kind of cascade effect here where many various proteins and enzymes in the body are interacting with each other. And so just like when you make a good recipe, you need all sorts of ingredients for it to come out right. Same is true of the body. And you can alter something and perhaps increase something or decrease something to have an effect. And so that's been the attempts, and there's been a lot of them. Some of you have been with us a very long time and remember that years ago there was an aha, maybe it's vitamin K, and it turned out no, it's not. Maybe it's magnesium, turned out not entirely, perhaps, maybe not. Lots and lots of studies have been done. Vilko's done some. Mark Lebel's done some, and several other groups in Europe, and certainly our own with pyrophosphate as well. So again, I'm just going to give you a very brief overview. Tomorrow, you will hear from the primary researchers about their ideas about treatment and where these are at in a much more scientific way than I'm going to be able to present to you in this short time. And I did let and have Vilko go on longer because I did think that was very valuable to all of you. So pyrophosphate, and let me just see if I can go back a slide. And I might not be able to. There we go. So remember that what we discovered some years ago through PXE international funding with Pete Borst in the Netherlands and with Cohn, who now is at the Jefferson Center, is that in fact pyrophosphate was a culprit in PXE. It's lower than people than normal, air quotes, people, and that causes perhaps a lot of what we're seeing in PXE. It does happen that when that discovery was made, that ABCC6 was in this sort of cascade with ATP and then eventually PPI, pyrophosphate, that in fact that decrease in pyrophosphate made sense because pyrophosphate, if you think about it in one way in very simplistic terms, protects the body from going kind of overboard in calcifying, because that's actually one of the ways the body heals itself is to use calcium and magnesium and other minerals. And so PPI helps to regulate that, to keep it steady, to keep it not over blown. And in people with PXE, we get mineralization in places we don't want it. And the PPI levels are too low to protect against that. It was thought when Pete Borst made that discovery with Kuhn that PPI was not, you couldn't ingest PPI and have your blood levels rise. There was a 50-year-old paper at the time that said it's really kind of an innocuous substance. You can ingest it and nothing happens. The FDA, in fact, had declared it as a food additive, and several other things like WHO and so on had said it's a safe substance because you can't really ingest it. It turns out you can, because Andras Varady decided that he, and you've heard him speak here before at other meetings, that he would not accept the dogma that said it wasn't ingestible and allowed the blood levels to rise. And he himself took it, and he had people in his lab take it. And he discovered that, yes, in fact, you can eat it and your blood levels will rise. Studies need to be determined whether or not it would actually make a difference in the progression of PXE. And we did a study, a small one, right before COVID in the PXE offices. And I'm actually going to give you a little snippet of a recording of that where Yoni Yuto describes what happens. I'm going to just make sure I have my sound on first before I do that, since Zoom can cause a problem with that. Okay. And so here's Yoni describing to the participants in the study. And so some of you will recognize yourselves here about pyrophosphate.
It's required for making organic pyrophosphate, or PPI. And this PPI normally prevents the calcification. So if you don't have the ABCC functional, as people with PXE have, then you don't make enough inorganic pyrophosphate, and therefore this kind of mineralization takes place in tissue. So that's pretty simple, right? Now, how do you then address the disease? One of the simple ways to think is that, yes, you put the PPI back, and that's why you are here, okay? There has been some very preliminary experiments by our colleagues in Europe. Basically, as Sharon said, just laboratory people doing it, and then we measure in the blood how much PPI is needed to increase the levels of PPI in your blood, and it's been a kind of little erratic way. They do too much, and as you heard, there were some GI problems, which we do not, we hope not happens here today, but then the bathrooms are both ways. So the idea is to give you a certain amount of the PPI. You take it by mouth, then we take blood samples at different times and we measure the amount of PPI and see how much you absorb and how long it lasts here. And based on the preliminary data, you get a peak, kind of nice peak at 30 to 60 minutes, and then it starts disappearing and should be gone at about 2 to 4 hour time point. So you are here not for a cure today, okay? But figure out if this molecule, PPI, or inorganic pyrophosphate, whether it gets absorbed when you take it by mouth, and how high the level in blood goes. And then we can adjust the doses in the future and look more in the details, how much you might actually need for prevention of the disease. So this is the very first, as we said, the very first time that PXE patients are given this drug in a systemic way and having the careful analysis. So
Okay, so that was Yoni
required
explaining
for
PPI. Another potential treatment that is in clinical trial progress, and you'll hear about this tomorrow from the principal investigator, is the Inozyme INZ-701. Inozyme is a biopharmaceutical company, and what they are looking for is whether or not this enzyme replacement therapy can actually address defects in ENPP1, which is another gene in the same general pathway as the ABCC6 gene. There is another condition called generalized arterial calcification of infancy. Children wind up with a very severe disease. Some of them die if they don't have treatment, and the treatments are not great. And that is the primary focus of Inozyme's drug, although they are also trialing it in a small number of people with PXE at the same time. And so tomorrow you'll hear about that. And then also tomorrow you'll hear about a molecule called a TNAP inhibitor, again in that same cycle, looking at ways to slow down PXE or mitigate the progression by a company called Daiichi Sankyo. And you will hear from Hubert Zoe tomorrow about that. In this case, the trial is being done in close collaboration with PXE International. I'm also an investigator on this, and many of you have heard from us about recruiting for this clinical trial. So those are pretty much the major studies right now. There are about maybe 6 or 7 other companies that have contacted PXE International. Since we have 5,000 individuals all around the globe, we're the logical place to do some of the recruiting. Some of it is also being done in large centers like Vilko's. He's involved in the Daiichi Sankyo trial. And some of these other studies are not yet ready for what we might call prime time, in the sense that they're not advanced very much, and or they're just in very preliminary stages. So we look forward to all of this work in treatments, and it's quite remarkable that a lot of tomorrow will actually be looking at treatments, looking at ways that we might mitigate symptoms for PXE. So different than, if you want an interesting comparison, go back to the recordings of our 1997 meeting, 1999, and you see that all we're doing is talking about mice and fruit flies and not about people, because we hadn't learned enough to be able to apply this to people. So I'll open this up for questions about the treatments, except that I'll say that anything specific about treatments you'll hear tomorrow, and just questions in general now we'll have some time for.
Sharon, I have a general question about, I guess, the treatments in FDA trials. So you mentioned, I think earlier, either today or yesterday, that one of the problems is there's kind of nothing to measure against for PXE. You're kind of measuring, to use the PPI example, whether PPI is going up or down, but that doesn't necessarily say whether it works per se or not in terms of improving PXE. So what does that mean in terms of the FDA pathway for approval of, the drug does what it's intended to do, but is the FDA going to say that's great, but we're still not going to approve it because we don't know if it actually works for the condition you're trying to treat? And in the Inozyme example, or in whatever example, is it more likely that a drug would be approved for a different condition and then be used off-label for PXE because of that challenge, for example?
Yeah, so great questions. The measures are not adequate in PXE, and it's kind of why I keep beating the drum that we need as many of you to participate as possible. And the examples I gave yesterday, and I'll give again because we have many more people here today, are things like, if you were taking a blood pressure drug, then they would simply measure your blood pressure to see that it worked. And in this case, you might say, well, just pay attention to my eye disease and see if it slows down. But we all know it's highly variable. Sometimes it's rampant and sometimes it's quiet. Sometimes it's different from person to person, almost always, in fact. And so if we had 20 years, we might be able to do a trial that looked at, for example, eye disease. We are looking at some new measures, and you'll hear about one of those tomorrow that might be useful there. You heard from Vilko that maybe various scans might be useful in terms of the vascular system. So until the FDA is, and we shouldn't say just FDA, EMA, which is the European Medicines Agency regulating drug development, until they're satisfied that the drug does what it says it does, there won't be an approved treatment for PXE. We are working as hard as we can to find that biomarker. It is not unusual to not have a good biomarker in slowly progressing, especially adult onset conditions. The condition I talked about, GACI, the generalized arterial calcification of infancy, is much more a dramatic disease, and it affects children. They can die by the time they're 2, 3, 4 years old. There are very strong markers in it in the sense of mineralization that's rampant and very, very accelerated. So you can tell in a very short time whether or not the drug is useful. Whether or not the regulatory agencies would approve a drug for off-label use from another drug, it depends. And so we all know, for example, Avastin was approved for use in cancer and anti-angiogenesis in cancer, but it is used off-label because we don't have a labeling for PXEI injections. All of them are used off-label because they're made for macular degeneration. The strength there, though, is that as it was used off-label, it was very clear that it was useful, and ophthalmologists continued to prescribe it off-label. So what we're looking for is evidence, is what essentially would be needed. And there's a whole bunch of evidence bodies in the world. There's Cochrane, there's NICE in UK, there's a number of these in the US as well. And so what we would be looking for is off-label use if we believed it was useful. However, clinical trials cost a lot of money and take a lot of time. And so we need to find ways to fund those as well. And many of you here have been very, very generous with donations to us. We just, as you all know, were able to meet the $150,000 offered twice to us in a campaign, and so have amassed a significant amount of money, but hardly anywhere near. If we raised $500,000, we're looking at something in the high tens and hundreds of millions of dollars to do the right studies. So long answer, no straightforward path yet. Okay, let's see what other we have for, and whether or not these trials are elsewhere. So the trialists tomorrow will talk about where the trials are being done. Again, because they're quite expensive, they're usually geographically limited. And what I keep saying to people is, while you might not be able to be in one of these phase 2 clinical trials, you absolutely can answer all the surveys. We're about to launch a whole host of new ones. And you are in a study then, and your being in that study is critically important. And whether or not these trials are recruiting, I'll leave that to the investigators tomorrow. Is it safe to say the trials are focused on stopping progression rather than curing and healing? It's a great question. I'm going to give a philosophical answer first. When we started PXE International in 1995, a lot of disease groups said cure. We're going to cure cystic fibrosis. We're going to cure sickle cell. We're going to cure arthritis. I'm not sure we can cure diseases the way we at least pretend we can. And we decided early on not to give false promises. We would say hope, not hype. We do not want to give anybody the impression that we can do something as magical as cure something. If we had a gene therapy for PXE, which we will, I don't know that I'll live long enough to see it, but we will have a gene therapy. It will cure PXE. I think these other treatments will stop the progression. The other question in that is, what about healing? That's a whole different question as well. So you could imagine that if today we arrested your PXE, meaning it's not going to go forward anymore, your body will not choose to put calcium, magnesium, other minerals in places where they shouldn't be, like your skin, eyes, arteries, that would be really terrific. However, that does not heal the vessels that are already damaged, or heal the membrane of the eye, or heal the lax and loose skin. The body itself remodels, it regenerates various cells constantly, some of them at much greater rates than others. If you get a cut, you know you've watched yourself build new cells and heal. That can happen as well in other parts of the body. Vilko talked a little bit about that in the vascular system. Other places like skin take a lot of years to turn over the cells, and so we probably wouldn't see the kind of regeneration there that we'd like. We are funding a researcher, John Schonecker at Vanderbilt, who has the idea that macrophages could actually eat up, like a little Pac-Man thing, the calcium, and actually heal. And so he's working on that. There are also lots of other kind of general researchers looking at calcification in general, because it's not a problem just in PXE, it's a problem in scleroderma and various arterial diseases and so forth. So I think we're probably going to see healing kinds of therapies come from other sectors, and not necessarily specific to PXE. But you are correct that, wow, the people who are really going to benefit from the treatments that we're talking about are those who have not yet had their angioid streaks progress to a place of bleeding, or their intermittent claudication progress to a place of blockages and so forth. And the others are going to need additional therapies as we work through this. We're not forgetting that will be true. And just like those of you who had injections and are not legally blind, we have not forgotten those of you who are legally blind, and we essentially have a number of communities within our community now because of the treatment. Okay, next one is UK. In UK, NICE approves drugs. Yep, not sure how others see in their notes, but my NHS trust has to note macular degeneration. Yeah, exactly, Helen. So that's true in the US. It's true in most developed countries that the retinologist has to write macular degeneration for the insurance companies, or the government insurance in Canada and UK, to pay for the treatment. And when they don't, so there are some countries where they won't, in the past, Hungary and Turkey, for example, a couple countries in Africa, then the person cannot get the treatment, which is a really sad thing. We did speak to, for example, Genentech that makes Lucentis and Avastin, and ask, can we show through medical record review that in fact these treatments are working for PXE, and you could apply to the FDA and get approval? They said no, they did not want to do that for a whole bunch of political reasons, and so we don't have any of the anti-angiogenesis drugs approved or on label. And all of the drugs are off license, off label. What else? Questions?
I've one other question. So how would you describe kind of the prospects for regulated drugs versus non-regulated treatments like magnesium, the vitamin K, things like that, that theoretically people could just buy as a supplement or kind of take on their own kind of going forward, in terms of, what is kind of where's the research? What is, what are the prospects for kind of those two channels, if that makes sense?
So most of these drugs you can't get. So I'm not sure exactly what you mean, Reed. Lots of people take lots of things with no evidence that it works or doesn't work. But for PXE,
okay, because like the things in the past, vitamin K, magnesium, those just sound like things you can buy at kind of the drugstore, and in like vitamins, and even the PPI, it's probably hard to get, but it sounds like you can just drink it and it doesn't have to be approved by a regulatory agency. So I guess my question is, what is the prospects for things that, don't have to be approved, versus things that would have to be drugs that would have to be approved by a regulatory agency kind of going forward?
Yeah, I mean, so when we did the magnesium study, and PXE International was both a funder and I was a co-investigator in that study, we certainly hoped it would be approved because, my goodness, then it's pretty inexpensive. We would have to reformulate it because the amount of magnesium we were talking about was much higher than, you could take 15 pills, but it'd be nice to have that in one or two. Um, the problem is that so far, any of these other substances, so like magnesium did not work, vitamin K did not work. So the next question is, okay, so, one of our board members, in fact, buys PPI by the tractor trailer truck because he's using it in his meat packing industry for the schools in America to make sausage. It's in cream cheese, it's in sausage, it's in chocolate, it's an emulsifier. However, the amount of PPI you have to take, and even drinking it, like I suggested there, the amount of diarrhea and projectile vomiting you have is unbelievable. So PPI has to be reformulated for us to even consider it. And we are in the process of looking at that. It's a complicated thing because the Netherlands Cancer Institute holds the patent on one formulation, and then there's a couple of other groups that have patented other formulations, and it makes it hard for PXE International to do any work on it because it's patented. So the problem with those other kinds of things that don't necessarily need the same level of oversight is, how are we going to test it for toxicity, for discomfort, that sort of stuff. And then the other thing that's really difficult is that when we did overload mice with magnesium, in some cases they had increased calcification. And when we did some vitamin K studies, it actually sped up PXE. So you could experiment on yourself and, in fact, inflict greater damage. And that's a real risk in any of these things. So for now, PXE International's bottom line is to continue to take the recommended daily amount of anything, calcium included, that is your country's standard. The US has one, many of the developed nations have them, and to not be playing with adding things that we don't know about yet. It would be nice if it does turn out to be something as simple as pyrophosphate or magnesium or whatever, because it would be much less expensive, since drugs for rare diseases are often very expensive at the end of the day because they cost a lot to get developed. Someone's asking about gene therapy. So I don't know about gene therapy in Mexico, particularly. I am part of a gene therapy consortium run by the National Institutes of Health that's global and that is looking at gene therapy for a variety of conditions, as well as I'm working with 4 or 5 countries and companies that are looking at gene therapy. I'm not familiar with experts in Mexico that have joined any of our consortiums, but I certainly could look at that. Again, there will be gene therapy for PXE at some point. We're actually a great target because this gene ABCC6 is largely expressed in the liver, and putting a vector into the liver is easier than some other organ systems. And so gene therapy is definitely going to make a difference at some point. However, we're years away from that. And so we keep trying in between to make sure we have a viable therapy sooner than later, with all the hurdles that we're facing. What else? Any question from the day? I think our experts are largely gone, but having hung around them for 28 years, I probably can answer most things, or we can make a note and get an answer to you.
I guess, one of the questions I'm thinking of it, if someone has kind of, primarily one symptoms of system, so like eye or vascular or whatever, are they more likely to develop symptoms of the other systems as well? So if you have eye, you're more likely at some point to get skin or vascular, or it really, you just don't know?
So my main answer to that is, if everybody would answer the surveys, I would know. But it's kind of remarkable that we have low numbers of people. We have 1,600 participants overall in the long studies, but there's only 200 that have answered the vascular section and 300 that have answered the eye section, and nobody answering all the sections. And so I keep beating the drum and asking and asking and asking, but until we kind of catalog everyone's experience of PXE, then we don't know an answer to a question like that. I can say from meeting 500 people with PXE, so this is completely non-scientific, just anecdotal evidence of my being with people. Some people have no eye disease their entire life and just skin. Some people have eye disease, and we really can't tell that they have skin disease unless they have a biopsy. Some people never develop any kind of cardiovascular or vascular disease. So it's highly variable as far as I can tell. But boy, would I love to know exactly the percentages of people, how it progresses, and so on. And if I did, then when I'm talking to the FDA in official meetings, they don't say to me, you clearly don't understand this disease, come back in 20 years. And I'm fighting them to say, I do, we'll get this thing done this year. So I will be on my crusade again. Bob, I see your hand up.
Yeah, my question was having to do with, now I've forgotten what it is. Can I lower my hand and remember what it was?
Yes, feel free
Thank
to
you.
do that. Yeah, no worries. What else for questions on anything?
Hi, Sharon. I wondered if, since you mentioned the liver, this is the first time I've joined this organization, and literally I was diagnosed at 11.
Mhm.
And because of my skin, I have eye symptoms and I have the claudication, and
Yep.
I'm a physical therapist, so I'm pretty active. But
Yep.
my question is you mentioned the liver. I mean, I'd always thought it was the elastin, but clearly it's this genetic issue and it's mostly expressed in the liver. Are there situations for people's livers? Like, should we not have alcohol? Should we make sure that we're, I don't know, taking care of our liver in very specific ways? I guess that's my question.
No. So it's I always almost hesitate to say PXE, the gene, is largely expressed in the liver. Actually, liver, kidneys, quite a few organs, and it's in every organ. And it's not a liver disease, though, in the sense that there is no malfunction of the liver, except this relatively small thing, like they will examine your liver and your liver levels, and they'll all be fine. In general, and unless you have some other process going on, because liver disease is especially non-alcoholic fatty liver disease is really prevalent in cultures like the U.S. So the answer is no. Of course, all things in moderation, alcohol in moderation, that sort of thing. A healthy liver, a healthy kidney, a healthy heart is all going to help a lot. I mean, there's a real interesting thing with PXE in that it is if we looked at it one way, and we don't often even say this, it's premature, slow aging. So we're getting a lot of the same stuff people get when they're 80 in 40s, 50s, 60s. And the way people stave off aging is essentially to exercise, eat right, all the things, make sure. I mean, I recently read a study that started in 1938 on what creates longevity and health. It's having a friend. It's having a person, your person, and not even one person. The study showed that if you look your coffee server at the restaurant in the eye and say hi, it does enormous things for your physiology, for your body. So that's way over on one end of the spectrum. On the other end of the spectrum, liver is not an issue. However, the liver is the place that does deliver or not deliver this PPI to the bloodstream. And so we need to fix that. But it wouldn't be considered a liver disease per se. And the other point there is, yes, in the old days, the first, 10, 15 years of PXE International, when we didn't know what is this gene doing, ABCC6, there were thoughts that, oh no, people with PXE are actually born with a structural malformation in elastic tissue. But then we said, not true. And if we and for example, in mice, we've interrupted PXE different ways, transplanted a liver that doesn't have PXE, and in fact, a few humans have had that happen to them both ways, that there is no PXE because the peripheral tissue is not set up to do PXE. It's set up to be normal, but then the liver is not cooperating, so to speak, and causes this low level of PPI in the body. So that is why we call it a metabolic disease, not a structural, in the peripheral tissue, a defect, so to speak. It causes a defect, but that defect is not baked into that tissue when someone is born.
Thank you. Thanks so much.
Yeah. Bob, you're back again, and maybe you remember?
I sure do. In the questionnaire that I've filled out, and I have the pen and everything, and I think I filled out all of them, although Lunar is really a bear to try to do. For one thing, you've got to have a cell phone to get a code to get into it. Some of the questions are oblique. That's not really the good word that I want, but it's they ask questions of, what do you have, this or this or this and this, and some of them I can't even answer. I do the best I can. What do you do with the ones that like people like me that can't answer the question?
We have a couple of ways of dealing with that. Just skip it, or Mary Pekakonis in our office is happy to sit on the phone and do a screen share and walk anybody through any questions.
What I'm thinking is that I'm really not happy about all the ways that I answered those questions. And if is that something I can make an arrangement for now that I'm fairly semi-retired and have hours and hours and hours to do, so that my questions there actually give you the information that I need to be able to give you? And some of the questions I don't have an answer to,
Right. Yep. Not everybody will have an answer to all the questions, but you can bet that if we don't have that question there, then we get a phone call right away saying you don't have a question about my thing. So there's a lot of questions, and we're asking everybody to do their best filling them out. We also ask you to connect your electronic health record, and then we can verify all of those questions and answers as well. So yeah, you can definitely reach out to Mary. Her email address, I put it in the chat, is mary@pxe.org. She's easy to find.
Well, I'm going to wait for her to get back from vacation anyway. I hope she's having a good one. We're getting up here where we're getting in Massachusetts. We're warm, but she's warmer where she's having vacation. Yeah, okay. Well, I'll send something down because I really don't want to have anything not being going to you. I've tried to link all of my EMRs to you.
Yep.
But one of the things is that my EMRs really don't like to link. And I've actually got things that simply indicate to me that maybe I'm not linked. So what I think I need to do is go over everything with her.
Yep.
And I will definitely send her an email, and thank you for the advice.
Yep, super. Yeah, between her and Georgia and Kat, they will solve any problems. So we're not going to triage those here because they do vary a lot for various people. And as I said, we'll be launching a whole new set of surveys. In fact, the ones that some of you answered on paper in 1997 are now all electronic, thanks to Kat and Georgia. And so we'll be sending those out very soon. Okay.
Well, whatever it is that I can do to help, I'm pleased to do. It's just that,
great.
Sometimes,
Thanks, Bob.
Sometimes it's really difficult to use Luna, and it's really hard to tie my EMRs to it.
Yes, so
whatever it is.
Take care of that. Yep, let's have Mary work with you. As we've said, there's EHRs, there's 700,000 electronic health record portals systems in the United States, 700,000, and we've built conduits with every single one, and they don't all work. So the institutions sometimes change things and so forth. So Mary will take care of that. Thanks so much.
You should hear what my
question.
you should hear what my PCP says about having to fill out the EMRs.
Yes, we've definitely heard that over and over. Okay, another question. My sister, a carrier not affected, wants to know if it's okay to take calcium supplements. She may have spinal issues. Everybody should take calcium supplements, PXE or not. So people who are carriers, no big deal. Take whatever the doctor says you should take. It is not calcium ingested in PXE that makes a difference. It's that the body is taking calcium and making mineralization in places that it shouldn't. And the example that was driven home to me early on, because I actually restricted calcium in my 2 growing children when they were 5 and 7 years old, because that was the advice in 1994, 95. The example I heard was they look at studies, for example, of women in underdeveloped nations who don't have enough to eat, and they're nursing, and their milk is perfect. It has all the calcium it needs. It has all the minerals it needs. And they leach it from their bones to give it to the milk. And the same thing happens in any condition where you restrict something, like your diet just does not have enough calcium in it. What's going to happen is it gets leached from your bones to keep your blood level normal, because calcium blood levels are super important. And so by depriving yourself of any of these minerals, it isn't that you're going to help your PXE. It's going to be that you, in fact, will hurt other parts of your body. And lots of people who were given this advice early on have osteoporosis now, which is not something that you want to live with. Okay,
Sure.
a link.
Oh.
I'm going to
Sorry.
go with a question in the chat, Reed. I'm
Okay.
trying to give everybody a chance to get questions out. A link with dementia and PXE. So that is a great question. We don't know. And I'm going to say we don't know a lot. It is possible that if our arteries in the brain are affected, that there could be this kind of dementia that's caused by not Alzheimer's. So that's a different disease. And of course, lots of people have it, and people with PXE can have any other diseases as well. But there's no link that's been established formally yet. And it's another thing, stroke, dementia, some of these other things that we didn't mention today that we really do want to get a handle on. And we're hoping if we get enough surveys in, we'll be able to know whether or not there is a link. Okay, Reed.
So one of the things I've struggled with, and some of the folks have talked about it to some extent, is how much exercise and what type of exercise is okay versus not. And I'm, very hesitant to do stuff that I used to do because I just don't want to kind of risk, declining, additional kind of vision issues. What is kind of your guidance on what's okay, what we should do because it's actually good, and what we should really try and avoid?
Yeah, so I would say avoid nothing. Avoid getting hit in the head regularly. So probably don't be hitting a soccer ball every day. Maybe avoid a baseball to the eye, those kinds of things. But I would say that to any human. In fact, our good ophthalmologists like Wayne have said everybody should be using eye protection in racket sports, for example, or ball sports. Anything else, cardiovascular exercise is really useful to your cardiovascular system. And, back to my comment that if you have a healthy body that has PXE overlaying it, then that you'll have a much better chance at not having severe symptoms. If you have a very sick body and you smoke and you are obese and you don't eat anything except McDonald's or, junk food, you're probably going to have a worse course of disease. And we've shown at least some of that in the studies we have done. So I would say exercise is great. I'm not sure why you'd want to alter it unless you were doing something that in fact would require a blow to the head or a blow to the eyes as part of this sport.
Okay, because Dr. Fuchs and maybe one or two other doctors have mentioned kind of not like heavy weightlifting, for example.
So what they mean by that is there's a thing called a Valsalva maneuver, and the maneuver is not done by good weightlifters. The maneuver is done by people who don't know how to weightlift. And the idea being that when you strain, and it might be that you're picking up something heavy, it might be that you're just wanting for whatever reason to kind of, close your ears, close your nose, close your mouth, and really push hard so that you increase the pressure in your head. I don't know why people would do that in general. But when you're trained to weight lift, at least the training that I've had in various gyms, CrossFit and others, good trainers do not ask you to do a Valsalva maneuver, to do that straining thing. Instead, they ask you to decrease the weight and get your form better. And so we do have some people with PXE who are lifting enormous amounts of weight, but they are not doing a Valsalva maneuver to do it. And that will vary a lot from person to person and to your own progression in working out to see whether or not you can progress properly, so to speak, in a way that doesn't allow the Valsalva maneuver to occur.
Thank you. That's super helpful.
Bob.
Just to the point about the Valsalva maneuver, I don't think if you have PXE, you want to be flying F-22s and F-35, since that's how you prevent yourself from blacking out under high Gs.
Right.
The other point I wanted to make, well, one of the points I wanted to make was that when Dr. Berkovich heard that my favorite drink, instead of water or Coke or, or Pepsi or whatever, is to drink milk. I drink a couple of gallons of milk. Well, actually, I drink about at least a half a gallon of milk a day, if not more. And he really wanted to do a study, but I couldn't get anybody down at PXE to be interested in the progression of my PXE, given the fact that I was drinking so much calcium. And I forget what the third one was, and I'll get back to it if you're still there.
Great. Yeah. So, again, taking calcium is fine and milk is fine. Obviously, anything that's in great quantities, you can think about yourself for lots of health reasons, not just PXE. Okay, we are quite a number of people are leaving and thanking us for the day. It's really been terrific to be with you. I'm so pleased with our presenters. They really were quite helpful to us, I think, and gave very good sessions so that you could ask a lot of questions. Tomorrow, we will be having a lineup of researchers. Looking forward to that as well. As I said in the past, that would be the sort of slimmest part of the meeting. And in fact, we now have the pleasure of having lots of research going on that's very meaningful for all of us. And so we're grateful to them. Some of them are coming to us from Europe, where it will be Sunday afternoon or evening for them, and others in the US, and some of them even very early, because we'll start again at 7 o'clock in the morning on the West Coast and noon on the East Coast and 1600 in the European time zone.